at University of Colorado Cancer Center, Aurora, Colorado, USA. Dr. Manali has been keeping the flag of India high in the field of lymphomas for the last couple of years, and is this short span of academics that she has had in US, she has made a great impact. She has been our regular faculty for the last couple of years. She has never said no, whether this is traveling all the way to India and talking to us, or whether it is through webinars. I have always got extremely impressed by the contents of her talk, the depth of her knowledge, and I do bother her repeatedly with various queries for the management of my patients through emails and telephones, and I must tell you that she responds in 2 minutes. So you can take liberty. I'm sure that she is going to answer all your queries in the management of your patients to improve that. So that's it. Over to our speaker, Dr. Manali Kamdar. You can share your screen now. I will get out. Thank you.
Thank you very much for this very kind introduction. Someone I have looked up to all my life, so this means a lot coming from you. So thank you very much. It's my pleasure, my honor to talk to everyone today about practice-changing updates in lymphoma. My task today is really to talk about all the updates that have happened over the year 2019 to 2020, and it is going to be a packed 1 hour. Be happy to take questions in the end. But moving forward, if I can, Kalpesh, are you able to advance my slide?
You are sharing your screen.
Great. So these are my disclosures. I do have research support for clinical trials from the Lymphoma Research Foundation, and I do sit on advisory boards for these pharmaceutical companies. So in terms of practice-changing updates, I really wanted to see what has really received FDA as well as EMA approval, which has led to bringing these medications and therapeutics to clinic. So of the 100 different types of lymphomas that we actually see in clinical practice, I decided to focus on 5 of these major subtypes of lymphomas where a lot has happened over the last 1 year. In 2017, I can tell you that my management for CLL was much different than what I do in clinic now. So moving forward, let's first start with probably the most impactful and practice-changing subtype of lymphoma, which would be chronic lymphocytic leukemia. So I wanted to give a little bit of a background. This was a study by Barbara Eichhorst in Lancet Oncology, which first established the superiority of FCR over BR, and the superiority was a statistically significant progression-free survival. And then there were multiple follow-up studies which looked at what really happened when these patients were followed over decades. And you can tell that this is where the first concept of mutated IGHV versus unmutated IGHV, and thus causing an impact on management, really bore fruit. So if you can see on the left side, if someone has an unmutated IGHV, whether you give FCR or whether you give BR, FCR may be slightly better than BR, but at the end of the day, the whole curve really goes down. On the other hand, if you focus on the right side of the curve, if you have a mutated IGHV, you can now begin to see a plateau in the FCR curve. When I talk about a plateau, that basically means that patients are relapsing less. And from a single center series at MD Anderson, they actually did show a plateau at the 15-year mark. And this is why FCR still is in the game for a certain subtype of CLL. Moving forward, in patients who are older, they of course cannot tolerate high-intensity chemotherapy. And this is where obinutuzumab plus chlorambucil was tested in a randomized fashion in comparison to rituximab chlorambucil versus chlorambucil alone. And as you can see, there is a statistically significant progression-free survival in patients who got G chlorambucil versus chlorambucil. At the same time, it also translated into a statistically significant overall survival. Take a look at these curves because we are going to talk about these in the context of coming up all the clinical trials that I will discuss. But this is the clinical trial that actually made G-chlorambucil the backbone. So you may actually see a trend wherein most of the future clinical trials are now being compared to chlorambucil or chlorambucil rituximab or chlorambucil obinutuzumab. Now, Gazyva or obinutuzumab is basically a more novel second generation antibody drug conjugate as compared to rituximab. And I do have to say that I have a particular bias towards obinutuzumab over rituximab, especially for patients with CLL, because we have seen over the course of number of trials that people who get obinutuzumab have a higher cytoreduction as well as have a higher minimal residual disease reduction. You'll again see a little bit of a trend into the number of trials that we will be discussing. Moving forward, Ibrutinib. So all of you know Ibrutinib made a big splash in 2014. It pretty much changed how we manage CLL in the 2000s. Prior to 2014, everyone historically got chemotherapy. On the other hand, when Ibrutinib made a splash, people actually started living. They also started living longer. This was the first clinical trial that was presented in the NEJM by Jan Berger, wherein patients who were older than 65 without deletion 17p were tested as initial therapy with CLL. And the comparator arm, as you can see, is again the straw man, but it has been shown that chlorambucil was somewhere effective. So the comparator arm is chlorambucil. And you can see there is a statistically significant progression-free survival improvement in patients who received Ibrutinib. Not only that, there is also a statistically significant improvement in overall survival as compared to chlorambucil. Now, one would wonder that obviously there will be an overall survival benefit, but actually in this clinical trial, crossover was permitted. So when you have crossovers that are permitted, you typically don't see overall survival benefit. So you can basically help understand here that Ibrutinib actually also really decreases mortality in patients with CLL. So this is the clinical trial that actually got Ibrutinib its frontline indication for patients with CLL. Now, moving forward, at ASH 2018, and then subsequently there were three very, very important manuscripts that were published in 2019, wherein Ibrutinib was compared to different agents in different age groups. The first trial that was presented by Tate Shanafelt was eventually manuscripted in the NEJM. This is an intergroup trial called ECOG 1912, wherein Ibrutinib rituximab was compared to FCR in patients who were younger than 65 years of age. And to everyone's surprise, in terms of progression-free survival, there was a statistically significant improvement in terms of Ibrutinib rituximab over FCR. At the 3-year mark, Ibrutinib rituximab was at an 89% PFS versus 72% PFS for FCR. Also surprisingly, there was an overall survival rate that was also statistically significant for Ibrutinib ritux versus chemoimmunotherapy, which was FCR. However, I do have to say that there were 4 deaths in IR and 10 deaths in FCR. So maybe the follow-up is a little short, but the fact that at the 3-year mark, the curves are beginning to separate, that again really underscores the power of Ibrutinib. And this is probably the first time that a targeted inhibitor, like a BTK inhibitor, like Ibrutinib, actually showed benefit in patients with CLL over a very intense chemotherapy like FCR. So this is where the age of precision medicine, this is where the age of targeted inhibitors really started coming into the fore. Tate Shanafelt also presented follow-up data at ASH 2019 of follow-up making sure what really happened to these curves. And these curves sustain. So there remains a PFS benefit, there remains an overall survival benefit. About 27% of patients on the Ibrutinib arm eventually discontinued Ibrutinib because of inability to tolerate its adverse events. However, the PFS and OS were still holding up at the 1-year mark. So I would have to say that in patients with CLL under 65, ibrutinib would be the go-to choice, except for this one subtype. So when they looked at pre-stratified analysis, they looked at IGHV mutation and IGHV unmutation. Remember, IGHV mutated CLL, especially for my trainees here on the call, basically means that the BCR-ABL receptor is shut, as a result of which it is sending signals intermittently to allow the CLL cells to grow. On the other hand, if you have an IGHV unmutated, that basically means that the receptor is always on the on mode. So it's constantly sending signals to make the CLL cells grow. Therefore, IGHV mutated is supposed to be a good prognostic factor. On the other hand, IGHV unmutated is supposed to be a bad prognostic factor. Now, when they looked at IGHV mutated and unmutated, they actually did see that in the mutated arm, there actually was no benefit over FCR versus IR. Now, remember, these are also patients who are not deletion 17p or TP53 mutation positive. So this is the clinical trial which continues the conversation of FCR. So the only factor or subtype of CLL where technically I would consider FCR, but also have a discussion of ibrutinib would be in patients who are younger than 65. They are IGHV mutated and they do not have deletion 17p or TP53 mutation. Remember, when you do deletion 17p, you do it on FISH. When you do TP53 mutation analysis, you do it on next gene sequencing. Doing it only on FISH does not exclude the possibility that you can catch it on gene sequencing. So if you don't find FISH that shows deletion 17p, it is always prudent, especially at relapse, that you do send for gene sequencing for TP53 mutation. Moving forward, ibrutinib was also compared in the older population to BR. Now remember, a lot of us have used BR in our clinical practice for a very long time. And this clinical trial really tells us that to do BR in 2020 may be a disservice to patients unless you're really treating a very frail patient who really needs a little bit of time to make it through. So in my clinical practice, I have typically abandoned Bendamastine and Rituximab because also there are opportunities for me to enroll on clinical trials. Besides, of course, there are non-chemotherapy targeted agents like ibrutinib. So this clinical trial that was presented by Jennifer Woyak at the plenary session at ASH 2018 and then subsequently made it to the manuscript in the New England Journal of Medicine compared patients who were older than 65 to either getting Bendamastine Rituximab versus Ibrutinib Rituximab or Ibrutinib alone. And you can see that the ibrutinib-based arms had a statistically significant progression-free survival over Bendamastine Rituximab. On the other hand, there was no overall survival benefit because crossover was permitted. Now, this trial actually establishes a couple of factors. Number one, ibrutinib versus ibrutinib rituximab is equivalent. So typically, if I was to do ibrutinib for some patient, then in that case, I will not combine that with rituximab because there is no benefit to adding rituximab over ibrutinib. Whether or not there is a benefit to adding ibrutinib plus obinutuzumab, we won't know. However, this was the Illuminate trial that actually compared ibrutinib plus obinutuzumab versus chlorambucil plus obinutuzumab in an extremely frail population. So the age group was a median of more than 75. And in this patient population, they actually did show, this was further published in the Lancet in 2019, that ibrutinib obinutuzumab was much superior to chlorambucil obinutuzumab in terms of progression-free survival, and it did not matter whether patients had bulky disease or not. Now, whether ibrutinib would have also been equivalent to IO, we don't know. But at this point in time, in my clinical practice, I typically just do single-agent ibrutinib. Of course, there are multiple other BTK inhibitors that are now currently available. But The big question is then, should we just close our eyes and treat everyone with Ibrutinib? Because there are now 3 clinical trials that actually showed that if you were young, Ibrutinib is better than FCR. If you were in the middle age group, Ibrutinib is superior to BR. And if you're older than 75, then Ibrutinib obinutuzumab is superior to chlorambucil obinutuzumab. And this is where really the challenge happens, wherein we are talking about adverse events with Ibrutinib. So all of us who have treated patients with Ibrutinib, we have seen patients at least 30% of the times who have these nagging side effects. And these nagging side effects really happen because Ibrutinib is a non-specific inhibitor. So it not only binds BTK, but it also will bind TEC, ITK, as well as EGFR. And because of that, patients can have muscle cramps, arthralgias, patients can have a rash, they can develop diarrhea. They also do have a slightly higher chance of atrial fibrillation as well as bleeding. Atrial fibrillation was documented in about 12% of patients with Ibrutinib, as well as bleeding was documented in about 10% of patients with Ibrutinib. So the big question is there a way where we can minimize these adverse events? How do we manage them? That's a completely separate topic in terms of how do I manage adverse events of Ibrutinib. I'm happy to go that into detail towards the end of this talk. But what I'm really getting to is now is really the age of second generation BTK inhibitors, wherein we have better molecules that are a lot more specific towards binding BTK, and thus they don't have any target effects on TEC, ITK, and EGFR. And I do have to say, I do have a lot of experience with acalabrutinib because I participated in the clinical trial, which eventually did get FDA approval. But in my clinical practice, acalabrutinib, I really haven't seen anyone get arthralgias, rashes, muscle cramps, diarrhea. However, acalabrutinib gives rise to 2 side effects, which you should know. These are early onset. These typically happen in the first 6 months. So patients typically complain of headaches. And the trick to really taking care of these headaches is having them drink caffeinated beverages. So coffee, tea, Coke, anything, it actually takes care of it. So they don't even need Tylenol. On the other hand, people can also get early onset diarrhea, which again is very responsive to Imodium as well as Lomotil. Usually patients come to my clinic and say, are you sure you're giving me something because I'm not feeling any side effects? I think historically in the world of oncology, we are meant to believe that everyone has to have side effects to assess that the drug is working. I think we are now entering an era where we are not only concentrating on making sure that we kill the cancer, but we kill that at the cost of less toxicity. And this is where I can tell you that CLL management has made the hugest impact. So getting back to the conversation of second generation BTK inhibitors, this was the Elevate-TN trial that my center participated in. This is a phase 3 study of acalabrutinib that was compared in newly diagnosed patients to Acala-G, and the G would be the obinutuzumab, compared to the Strawman, which was chlorambucil obinutuzumab. At a median follow-up of 28.3 months, the PFS was statistically significant in the Acala arms. In fact, the numbers are small, but if you look at it very closely, the Acala-G performed slightly better than Acala monotherapy as well. Overall, atrial fibrillation rate was 3% and the major bleeding rate was 2%. Now remember, this is in stark contrast to Ibrutinib, where the AFib rate is slightly higher. Now we are cross-comparing across trials. We don't typically like to do that when we talk about clinical trials, but thankfully there is a clinical trial that is currently underway that is comparing Acala to Ibrutinib, so we will probably know for sure which is a better tolerated drug. But I'll tell you that in my clinic, I have had no issues with acalabrutinib, and this is the clinical trial that actually got its FDA approval in the United States this year. And Cll plus or minus obinutuzumab is what the package insert says. Again, there are times when I do obinutuzumab, but honestly, if I was to choose whether or not I want to do a combination versus single agent, I typically prefer acalabrutinib. Now, for all the physicians on board as well, typically I also say that although Acala or Ibrutinib, they don't have a lot of side effects, but you can't really start the patient on a drug and bring them back 3 months after clinic. You have to follow them very closely. So in my clinic, I actually have developed a programmatic approach where I see patients weekly for a total of 4 times. Then I move over to every other week for the month. And then I move over to every 8 weeks. And then get them to every 4. As long as they are doing okay, they will be fine. Now, with acalabrutinib as well as ibrutinib, I do want you to know that there is what we call a class effect. A class effect is what we call, it is basically what happens because of the function of the drug, the way it works. The way this drug works is really it removes or sucks out the lymphocytes from your lymph nodes and then brings it into the peripheral blood and targets it for destruction. As a result, when you first give Acala or Ibrutinib to patients, you will see your white count jump up. Your white count can go from a baseline of 60,000 to even 200,000. As long as it doesn't affect your hemoglobin or your platelets, do not discontinue the drug. It's also important to know that this drug can cause bleeding. It's almost like giving a 325 milligrams of aspirin. It works like that. It almost has a von Willebrand factor-like effect. Therefore, for any minor or major elective surgeries, I typically hold a BTK inhibitor 3 to 7 days prior to a minor and a major procedure respectively, and then resume it again 3 to 7 days after a minor and a major procedure respectively. So moving forward then, let's switch gears to the new kid on the block, which was venetoclax. Now, this was a clinical trial that was presented by John Seymour in ASH 2018, wherein they talked about the Murano trial. So venetoclax is a BCL2 inhibitor, so it targets the apoptotic pathway, and it actually showed huge responses in people who were multiply relapsed with CLL, even those who had failed ibrutinib. So Murano was basically a relapse refractory CLL trial wherein patients were randomized to getting Bendamastine rituximab versus venetoclax rituximab. Now, the first time that this has ever happened in the field of CLL was when you give a non-chemotherapy. Remember, ibrutinib or Acal, you give it until the patients fail the drug or develop side effects. So people are on it forever. This is the first time that a targeted inhibitor was only given for 2 years. So now we are emerging into a field wherein we are talking about venetoclax and rituximab given only for 2 years. And in this clinical trial, at an unprecedented rate, there was a huge PFS benefit to Venritux versus BR. And the overall survival benefit was also seen. And at a median follow-up of 4 years, Dr. Seymour at ASH 2019 presented that this was holding up. At the 4-year PFS mark for Venrituximab, it was 57% versus only 4% for BR. On the other hand, 4-year overall survival was 85% versus 66%. Now, this is also where the concept of MRD came into being. MRD basically means minimal residual disease. Minimal residual disease is a concept that is going to gain momentum. We are going to make treatment decisions 5 years from now based on MRD. FDA is going to approve MRD, and then eventually everyone is going to have to send MRD. So what is MRD? MRD basically is the amount of clonal CLL cells that you see in a pool of normal cells. So MRD can be done by flow, wherein the pool of normal cells, so you find one CLL cell in the power of 10 to the power of -4. On the other hand, if you do gene sequencing or PCR-based analysis, you're looking at 1 in a million cells. Now, MRD basically tells us what is the level of cytoreduction. If your MRD is negative, that means you actually are not able to really see any CLL cells anymore. And this is where the concept has borne fruit, wherein if you don't see any cancer cells anymore, why don't you stop treatment? And this is exactly what we found in the Murano update at the 48-month median follow-up mark, that if patients had an undetectable MRD at end of treatment in the venetoclax arm, these patients enjoyed really long progression-free survivals. So this is something that just keep it in mind. We will be talking about MRD moving forward. So because venetoclax obinutuzumab did so well, actually venetoclax rituximab did so well in the Murano study, obviously the way oncology works is if something works in the relapse setting, we move forward and test it in the frontline setting. And this is the Cll14 study that was presented by Kirsten Fischer of the CLL Germany group, wherein venetoclax obinutuzumab in newly diagnosed patients, of course these were patients who were older than 65, or they had a CIRS score, which is a comorbidity index score of more than 6. These were patients who were randomized to venetoclax plus obin versus chlorambucil plus obin. Now, the one thing about this trial is that this was also given in a time-limited fashion. Obinutuzumab was given for 6 months. Venetoclax was given for only 12 months. So this is the first time that they were actually doing targeted upfront therapy only for 1 year. And at a median follow-up of 39.6 months, which was also presented at ASCO of 2020, the 3-year progression-free survival was stellar at 82% versus 3-year PFS of 50% in patients with chlorambucil plus obinutuzumab. Now, of course, they looked at subsets. For example, how did the TP53 patients do? And I do have to say that in patients who were either deletion 17p positive by FISH or TP53 mutation positive by gene sequencing, these patients actually did have the second curve is those patients. If they got Ven plus Obina, they did well. They definitely did better than people who got chlorambucil plus obinutuzumab. However, the curves are not holding as well as the curves are with non-TP53 aberration patients. They also looked at MRD, and they did find that if your MRD was undetectable at the end of treatment analysis, then your PFS was excellent. You can see those curves really flatten out. On the other hand, if you have detectable MRD at the end of treatment, number one, we don't know if we should stop venetoclax. Number two, we don't know if we can continue venetoclax. So at this point in time, all we know is if we have detectable MRD, these are the patients who typically will continue to not have a plateau. Similarly, they looked at mutation analysis. And I do have to say that people, if they are mutated, they actually do very well. Surprisingly, people who got chlorambucil obinutuzumab, and if they have a mutated CLL, no TP53, no deletion 17p, these are patients that don't do as bad. So I would say in a frail patient who really has to make it for another couple of years, 3 years, doesn't want to get venetoclax, I would say if he's mutated, then I may think of doing obinutuzumab. I honestly don't quite understand the benefit of chlorambucil plus obinutuzumab. I think this benefit is basically coming from obinutuzumab than chlorambucil obinutuzumab. So if I ever choose that combination, I typically do it just single agent obinutuzumab. Again, because of the excellent results that were demonstrated, this is now FDA approved as well. So now we have a different dilemma in our clinic. In our clinic now we are really talking about 3 FDA approved agents for newly diagnosed CLL. You could either do single agent Ibrutinib indefinitely. One could talk about time limited therapy with venetoclax obinutuzumab for 12 months, or one could talk about 8 plus or minus obinutuzumab indefinitely. And honestly, at this point, it all depends on data. We know that if someone fails Ibrutinib, venetoclax works. Do we know if someone fails venetoclax, does Ibrutinib work? And this was a retrospective analysis across 31 sites in the United States, wherein Anthony Mado from Sloan Kettering actually presented this data at ASH 2019. And if patients stopped Ibrutinib because of intolerance and then got on venetoclax and then failed venetoclax, they do have good PFS if you restart BTK inhibitor. However, if patients progressed on a BTK inhibitor, then got on venetoclax, and then got back on BTK inhibition, then their PFS was dismal. So I wouldn't re-challenge patients post-venetoclax to getting ibrutinib if ibrutinib was discontinued because of progression. This is also where the power of allogeneic transplant and CAR T cell therapies is underscored. You can see in the bottom right that the PFS for people who underwent allogeneic transplant or CAR T after failure of venetoclax actually has not been reached. So these are the two strategies of management that continue to hold true. So just take home for CLL 2019-2020, like I said, for frontline, make sure you send your IGHV mutations, FISH analysis, gene sequencing. Ben-Obin is certainly something that I talk to my patients about. Acalabrutinib is my go-to BTK inhibitor over ibrutinib. Remember, ibrutinib and Acal are both efficacious in the same comparison. They are not higher than each other. However, the tolerability of acalabrutinib has been a lot better. So patients really don't have those nagging side effects. On the other hand, for relapse CLL, remember Murano actually is a good evidence-based trial that tells us that Ven plus Ritux for 2 years definitely shows a good 4-year PFS, especially if patients attain MRD negativity. Now remember, there are now going to be newer problems. The newer problem is that what if people fail venetoclax? What if people fail ibrutinib? Then what? And this is where I will have to say that I didn't have time to show you the CAR T data, but it looks excellent. So CAR T as well as allogeneic transplant for the fit and young patients who have failed venetoclax and ibrutinib, think about those strategies to get them back into a remission. Let's switch gears. Let's talk about diffuse large cell lymphoma. So there were about 3 updates, and I would have to say that this is probably the most important update in diffuse large cell lymphoma. And this was an update that was presented by my colleague at SWOG, Dan Persky, on behalf of all the SWOG members in patients with limited stage diffuse large cell lymphoma. Now, limited stage diffuse large cell lymphoma is not a big cohort, but it makes up for about 25% of patients. The SWOG trial, the old SWOG trial, actually showed that 3 cycles of CHOP plus radiation was good enough in terms of PFS as well as OS benefit compared to 8 cycles of CHOP. So that is what made CHOP 3 cycles plus radiation treatment the standard of care. And of course, when rituximab came into 4, everyone started doing R-CHOP for 3 times plus radiation treatment. My colleague at SWOG, Deborah Stevens, actually did a follow-up analysis, and she did find that in patients with limited stage diffuse large cell lymphoma, there wasn't really a plateau. So people kept relapsing beyond the 9-year mark. So which basically means we certainly can do a lot better in this subset. So moving forward, the FLIER study was published at ASH 2019, and the FLIER study compared in limited stage diffuse large cell lymphoma, if you have an IPI of 0, that 4 cycles of R-CHOP are equivalent to 6 cycles of R-CHOP. This is what made 4 cycles of R-CHOP the standard of care for diffuse large cell lymphoma. However, the critique of this trial was, well, it wasn't really compared in IPI that was higher, as a result of which this was the PET-directed therapy that was presented by Dan Persky, wherein patients with stage 1-2 diffuse large cell lymphoma were given 3 cycles of R-CHOP, and then they were randomized based on interim PET. If the interim PET was negative, they only got 1 cycle of R-CHOP. If the interim PET was positive, they went ahead and got radiotherapy, followed by Ibrutinib Diaxitan, which is radioimmunotherapy. Now, thankfully, in this subset, only 11% of the whole cohort was interim PET positive. So typically, we were concentrating on interim PET negativities right from lymphoma, and you can see these graphs are stellar. So the PFS curve, 5-year overall survival, is 90%. So together with the FLIER study in younger patients, this trial actually establishes R-CHOP times 4 as the new standard approach for patients with limited stage diffuse large cell lymphoma. I would have to say in my practice, I still give the option of 3 cycles of R-CHOP plus RT. On the other hand, if I have a younger patient, I typically recommend 4 cycles of R-CHOP, provided after 3 cycles, the interim PET is negative. There was no difference in the small set of population who had double hit lymphoma, double expressor lymphomas, ABC, GC. They did do that stratification, but the numbers were too small to make any overarching conclusions. Let's move forward to what we would say is the most unmet need in the field of relapsed refractory diffuse large cell lymphoma. So as you can see, about 60% of patients will be cured with our job. And 40% who relapse, of those, 50% will be transplant eligible. People who go through transplant, 40% will relapse. So really we are talking about a 30 to 40% of patients with diffuse large cell lymphoma who will not respond to upfront R-CHOP, who will not respond to auto-transplant, or who may not be fit for an auto-transplant. And this was what we call the Scholar 1 analysis. That was a pooling of about 5 trials, 3 retrospective, 2 prospective, and they found what is the overall survival in these patients who fail therapy after therapy. The overall response rate in these patients is a dismal 26%, and patients' median overall survival is only 6 months. The 2-year overall survival is 20%. Now focus on these curves because we will now show you in terms of all the new therapeutics, what has really happened with those curves with the newer generation agents. And moving forward, let's talk about Polatuzumab. So Polatuzumab is a trial that my center participated in. Polatuzumab is basically an ADCC that combines to a surface antigen that expresses CD79B. B cells express CD79B. After they sit on CD79B, it gets internalized and it releases MMAE. MMAE is basically a chemotoxin and it's very similar to Vinca. Therefore, Polatuzumab can cause neuropathy, Polatuzumab can cause neutropenia. So beware of that. Polatuzumab can cause constipation. It's the MMAE that basically targets the cell for apoptosis. So this was a phase 2 small randomized trial which randomized multiply relapsed refractory diffuse large cell lymphoma patients to either getting Pola-BR or BR. And in this clinical trial, they actually showed an unprecedented improvement in progression-free survival. And to all our surprise, there was also an overall survival improvement. There was no difference whether we got patients treated on non-GC or GC DLBCL. The Pola-BR CR rate was 40%. BR only gave a 15% CR rate. But you can see that the median PFS was holding at least 14 to 11 months. And because of this, Polivy or Polatuzumab is now FDA approved for patients who have failed 2 lines of therapy. Moving forward, I will not spend more time on CAR T cell therapies because it's a separate topic in itself. But CAR T really changed how we manage our patients. Previously, historically, patients used to succumb to their cancer, and I cannot tell you how much we have changed with respect to CAR T as well as Polatuzumab. So with respect to CAR T, we currently are working with 3 constructs. So my center is working with Lysocell. However, we do have FDA approvals on Axicell and Tisagen-Leclucel. Now remember, CAR T basically is where you have one arm that binds to the T cell and the other arm that binds to the lymphoma cell, as a result of which the T cell gets targeted for lymphoma killing. The co-stimulatory domain, which I have highlighted here, is very important because in Axicell, the co-stimulatory domain is CD28. In Tisagen-Leclucel, it is 41BB. In Lysocell, it's also 41BB. With CD28, you get a rush, so it's rapid and high. With Tisagen-Leclucel and Lysocell, it goes slow and then it peaks very, very, very slowly. There is also more persistence if you're talking about co-stimulatory domains. And because of this function of these constructs, if you look at Axicell, there are more side effects versus people who have a co-stimulatory domain that contains 41BB. So the logistics are very cumbersome, and I agree. There is apheresis, then there is laboratory manufacturing, which takes about 3 weeks at least, and then there is infusion of CAR. After we give CAR T cells, in the first 8 weeks, we look at 2 side effects, which are very novel. One is cytokine release syndrome, and the second is neurological toxicity. CRS is managed with tocilizumab. Neurological events are managed typically with steroids. And more than 8 weeks out, people can end up having prolonged cytopenias, B-cell aplasia, or opportunistic infections. So moving forward, this is a cross-comparison comparison across all the 3 CAR T cell clinical trials. And you can see that, remember, the overall response rate in this heavily pretreated population was only 27%. And this is where we are with a 6-month CR rate. We typically say that if at the day 90 mark, if a patient is in a good response, that is the patient that is most likely going to sustain a plateau with respect to future benefit from CAR T. And you can see that across the products, you basically have a 6-month complete remission rate of 36 to 53%. You cannot cross-compare across trials because Axi-cell was the front runner, then came Tisocell, then came Lysocell. Now, in terms of side effects, however, the Lysocell product certainly shows that the CRS and the neurotoxicity rate is a lot less than Axi-cell. And again, that brings you back to the discussion of which is the co-stimulatory domain. I also am aware that India is really looking into CAR T cells. The biggest challenge in the US right now is the money that really is poured into making one product. It costs $375,000 per patient. So it's really going to be huge for India to make products like CAR T at a much more subsidized rate. It'll make a huge impact in the field. So in terms of how does it really hold true? With Axi-cell, as you can see, if you are in a complete remission, your curve actually is flat. So that is impressive. With Tisocell, you have a median of 22 months. And with Lysocell, that's the same theme that gets repeated. That if you have a complete response rate, you do good on CAR T, and it's very likely that your survival will continue to be sustained. So moving forward, these 2 got FDA approved. So currently for relapse refractory diffuse large cell lymphoma, we have these options available. So what is the take home for DLBCL for the last 1 year? It would be that for limited stage DLBCL management, in a PET directed approach, not in a CT directed approach. This only applies for PET, Deauville score of 1 to 3. In a PET-directed approach, 4 cycles of R-CHOP is now the new standard of care. However, I would have to say 3 cycles of R-CHOP plus IFRT is something I still give to my patients over 65 years of age, especially if they want to get done with less chemo. On the other hand, for relapse refractory diffuse large cell lymphoma, for people who are ineligible for an auto transplant or failed after an auto transplant, you have these 2 options. Pola-BR gives you a median PFS of about 15 months, so you will need to come up with strategies after what. There have been few long-term survivors on this trial. Some of my patients are now at the 24-month mark. However, most of them will relapse. So Pola-BR sometimes can also be used as bridging therapy till a patient gets to CAR T cell. Let's talk about follicular and marginal zone lymphoma now. So for survival in follicular lymphoma, historically we have said, oh, you have follicular lymphoma, you're going to live a very long time. That is true. The 10-year overall survival is good. It's 80%. But does it make sense for a 40-year-old? You're telling a 40-year-old that the chance that you will be alive is 80% when you turn 50, which means there is a 20% chance you may just die because of your lymphoma. So which basically, again, underscores that we have a lot to do in this subtype of lymphoma. This was also a clinical trial that was published in the BJH by Brian Link, which actually showed that people with follicular lymphoma, 57% basically had lymphoma-related deaths. That's the blue curve on the right side of the graph. So keep that in mind because there is a lot of work to be done in this subtype of follicular lymphoma. The most important piece that has come out of multiple clinical trials is this concept of POD24. What does POD24 mean? POD24 means that 20% of patients who get upfront treatment will progress within 2 years of getting chemoimmunotherapy. That is POD24. And it is amusingly replicated in no matter which clinical trial you see. So in the first SWAP trial, which looked at R-CHOP, about 20% of patients will relapse within 24 months. In the Gilles-Sal PRIMA analysis of rituximab maintenance, 20% of patients will relapse at the 24-month mark. And then in the Rummel data, which compared BR versus R-CHOP in indolent lymphomas, again, 20% of patients will relapse. So Laurie Sen at the BCCA basically looked at who are these 20% of patients. It was a retrospective analysis. And they found that 70% of these 20% of patients who relapsed within 2 years, these patients had transformation. So our job is to make sure that we sieve out those patients and not expect that they still have follicular lymphoma. So if your follicular lymphoma patient, after getting chemoimmunotherapy, relapses within 2 years, it is incumbent upon us to do a biopsy to rule out transformation. I typically do a PET scan. I target the biopsy at the hottest site because that is where the bang for the buck is. And if that is not transformed, then too we are in a little bit of a soup. And the reason for that is because people who relapse within 2 years, the 5-year overall survival is only 50%. It is okay for someone who is 85 or 90 years of age. It is not okay for someone who is 45 to tell that person that the 5-year overall survival, because you relapse within 2 years, is only 50%. So this is where clinical trials again come into fore. Marginal zone lymphoma follows follicular lymphoma. So you can see the same trend in marginal zone lymphoma patients as well. Augment Study. So Augment Study was a study that really did change our clinical practice. This was a phase 3 study in patients with relapse refractory follicular as well as marginal zone lymphoma, wherein patients were randomized to getting Ritux lenalidomide for a total of 12 cycles versus rituximab plus placebo. Very few placebo-controlled trials happen these days, so this would probably be one of the last. But surprisingly and interestingly, because now we have an option, the PFS was statistically significant in patients who got R-squared. The median PFS was 39 months. And surprisingly, the overall survival in the follicular lymphoma cohort was statistically significant as well. Anyone who got R-squared versus R did much better with respect to overall response rate, complete remission rate, duration of response, time to next chemotherapy. All of those were significantly higher in the R-squared arm, as a result of which this also garnered FDA approval. So moving forward, what are the take-home points for follicular and marginal? Remember, 20% of patients will relapse within the first 2 years. These are POD 24 patients. It is extremely important to rule out transformation in that subset, and after that, make sure that the follicular lymphoma, true follicular lymphoma patients get newer therapies. Similarly, rituximab and lenalidomide is now considered as one of the standards for relapsed follicular lymphoma and marginal zone lymphoma. Remember, previously we just altered chemo. So someone got RCVP, then we moved on to BR. Someone got BR, we moved down to our CVP. Now we have the ability to do lenalidomide and rituximab, and I do have to say that this combination, keep that in mind, because a lot is happening with this combination, because it's chemo-free. Lenalidomide is immunomodulatory agents. Patients don't have nausea. Patients don't lose hair. So cosmetically, it's also a lot more appealing. There is some excellent data presented by Loretta Nastupil at ASH 2019, wherein she used lenalidomide and obinutuzumab in upfront follicular lymphoma, and the PFS was near 100%. So that is a combination to be watching out for. Mantle cell lymphoma. So mantle cell lymphoma is, particularly my interest. I really want to continue to build a niche in this subtype of lymphoma. This is basically the Esmo Guidelines. And the Esmo Guidelines say that in young patients who are younger than 65, you have to give them dose-intensified chemotherapy. And if they respond, take them to an auto-transplant followed by rituximab maintenance. On the other hand, for older patients, you give them conventional non-intensive chemo such as RCVP, Bendamastine, rituximab, and then put them on rituximab maintenance. What we decided to test in this SWOG study was the benefit of giving in transplant-eligible patients our Bendamastine as compared to our hyper-CVAD, which is a very intense regimen, followed by an auto-transplant. There used to be this notion that if you give Bendamastine, you cannot stem cell collect. And that actually has been founded to be untrue. In this study, our group actually showed that the 5-year PFS as well as overall survival was excellent. It was over 80% in patients who got R-Benda or R-Hyper-CVAD. There was no issues with stem cell collection in the R-Bendamastine arm. In fact, patients had less toxicity in R-Bendamastine. So based on that, I frequently do R-Bendamastine in my practice, whether or not I'm taking a patient to an auto-transplant. Now, does this apply to people who have blastoid mantle cells? Does this apply to people who have TP53 mutation mantle cell? There were very, very few number of patients in this analysis, so you can't make any conclusions. So in those patients, I typically try to add cytarabine. So I tend to give RBAC to these patients who are at a higher risk in terms of just their initial prognostic analysis. This is something that has changed how I manage my patients, and I can tell you that this was an analysis done with TP53 mutation, which is not deletion 17p, but TP53 mutation that is done on gene sequencing. And this study basically showed that if you have a TP53 mutation, then there is very limited benefit to taking these patients to an auto transplant. So very frequently in my patients who I'm taking to an auto transplant, I test them for TP53 mutation. And a lot of times if they are positive, which can occur in about 30% of patients with newly diagnosed mantle cell lymphoma, these are the patients I don't take them to an auto. I put them on maintenance rituximab, hoping that when they relapse, they get more novel agents. How to think about TP53, because sometimes it's a cost-restrained issue. And I would probably think of it if you have blastoid mantle cell, Ki67 of more than 30%, or a very high risk MIPI score. So that's when I think about checking for TP53 mutation. So in terms of molecular pathogenesis of mantle cell, it follows CLN. So again, the BTK signal is very active in mantle cell. So is the BCL2 signal. And based on that, these are the 4 approved agents right now. Ibrutinib certainly has done very well. Previously, patients had no option with mantle cell that came back after chemo. And chemo after chemo wasn't going to give or do them any good. So you can see with Ibrutinib, the CR rate is not that stellar, but it's still 20%, with the median duration of response of 17.5 months. And then, of course, there are these new kids on the block. The single agent venetoclax, small study, but which showed a CR of 21%, acalabrutinib, a CR of 40%. It looks that it is higher than ibrutinib, but these patients actually were not as heavily pre-treated. So therefore, the sooner you get them on a BTK inhibitor, the better their response will be. Therefore, the better their median FS is. But remember, irrespective, the median duration of response is at a max of 26 months. So if you have a relapsed mantle cell lymphoma patient at age 50, who you start on ibrutinib or acalabrutinib, relapses at 52, we need to have options for these patients. And this is where the Mike Wang study with CAR-T that was presented at ASH 2019 created a huge storm. It was a 68-patient study. It was tested in a very, very heavily pretreated mantle cell lymphoma population. Most of these patients had failed ibrutinib. 17% of patients had TP53 mutation. And this was the stellar result. The CR rate was 67%. The grade 3 CRS and neurotoxicity was manageable. Duration of response actually has not been reached. And the progression-free survival and overall survival at a short median follow-up of 12.3 months actually looks fantastic. And we are anticipating that the FDA will approve it in the next 3 months. So that will be another line that you can actually start thinking for your mantle cell lymphoma patients. So I'm hoping to establish that with all the advances in science, non-chemotherapy-based immunotherapy is really going to take a huge precedent for any lymphoma that we will be managing in the future. So take home for mantle cell would be that I think BR is a good induction regimen, but whether or not to use it in blastoid mantle cells, I would probably add cytarabine and give RBAC instead of BR. TP53 mutation, you do need to fish for it. So make sure you do it, because if someone is mutated, then I don't think there is any benefit of taking these patients to an auto transplant. BTK inhibitors, BCL2 inhibitors are here to stay. There was a Constantine Tam presentation at ASH wherein he combined ibrutinib as well as venetoclax together in a time-limited fashion. So this is where the field is going, wherein we are talking about non-chemo immunotherapy for a short amount of time. And then based on MRD, we either stop or we start again. And again, CAR-T clinical trials, I cannot tell you enough how much of a lifesaver it has been for many patients who would have historically otherwise passed away. So coming to the last update would be Hodgkin lymphoma. And Hodgkin lymphoma, I'm going to really give updates because there were too many that came around, and I would have to start with limited stage favorable Hodgkin disease. Now remember, for limited stage favorable, based on the GSHG criteria, which would be less than 3 nodal sites, no B symptoms, normal ESR, no bulk, these are the patients. Currently, the standard of care is 2 cycles of ABVD plus 20 gray of IFRT. This clinical trial basically said, okay, let's keep that as a standard arm, but in the experimental arm, let's do a PET-directed approach. So after 2 cycles of ABVD, let's follow it up with a PET. If the PET is negative, avoid RT. If the PET is positive, give RT. And what this trial actually established, that you cannot do this. There is significant loss of mortality. 5-year PFS is 93% in the RT arm, 86% in the no RT arm. So you really cannot omit RT. If you're giving 2 cycles of ABVD plus 20 gray IFRT, irrespective of the PET, you will continue the 20 gray IFRT plan. Now, this is something that we have seen a lot, that based on PET scan, it doesn't change what the PET scan actually overcomes the initial prognostic index. So in advanced stage Hodgkin lymphoma patients, we do what we call an IPS score. And an IPS score of about 5 to 7 will make your cure rate go down to 65%. And we know that these patients don't do as well. However, if these patients have an interim PET, which is negative, then it actually doesn't matter what their IPS score is. And therefore, the statement that PET-CT overcomes IPS, which again tells you, scientifically, we can now design studies that if your PET is positive, you can escalate therapy. If your PET is negative, maybe you can limit therapy. Because we, of course, want to cure Hodgkin, but we also want to limit toxicity. So RATHL was the first study that was actually aimed to reduce bleomycin toxicity based on PET-based approach. Radiation treatment was not part of RATHL, and basically they showed that if after 2 cycles of ABVD, if the interim PET is Dovel 1, 2, or 3, then you can safely drop bleomycin and just do ABD for 4 cycles. With this clinical trial, the 3-year PFS was about 85%. So all of us incorporated this in our clinical practice. The next day, it got presented. However, this was something that is more intriguing than practice changing for me. And I can tell you that PET2 negativity is something that still has to evolve. Because remember, Dovel scoring is how we assess PET. And there are times that your interim PET is a frank Dovel 4, versus there are times when your interim PET is 3 everywhere, but it's 4 at one spot. Should you escalate therapy for that or should you not? At the same time, if your PET is stone cold negative, a lot of us say, oh, you know what, this is good, my patient is going to do fine. But this was a study that was actually analyzed by Debbie Stevens at SWOG at a median follow-up of 5.9 years on this SWOG PET-directed therapy. She actually found that nearly 25% of patients in the PET-negative arm relapsed. On the other hand, if you are PET2 positive, which means you're Dovel 4 or 5, if you give BRCOP, your survival is actually pretty good. However, the rate of secondary cancers is 14%, which basically underscores that we need to do a lot more in Hodgkin as well. Now, of course, we all get super happy when someone has Hodgkin versus non-Hodgkin because we know someone has a potential of a cure. But remember, these are the nuances, and eventually all of us want to cure 100% of our patients. So based on that, these are the novel therapeutic options. One is Brentuximab. Remember, this is also an ADCC that released this MMAE like Tuzumab does, so people can get neuropathy, neutropenia, constipation. But in a heavily pretreated Hodgkin lymphoma population, Brentuximab caused a CR rate of 34%. And then there was checkpoint inhibition with pembrolizumab, nivolumab, with a CR rate that's not impressive at 16%, but an overall response rate of 70% in a very heavily pretreated Hodgkin lymphoma population. So moving forward, of course, if these agents do well in the relapse setting, you bring it up front. Echelon 1, the disclaimer is that I'm actually on the Speakers Bureau for Brentuximab. However, this is a clinical trial that I do believe in, as well as I definitely have implemented this in my practice. So this is a regimen where in stage 3-4 classical Hodgkin lymphoma patients were randomized to getting ABVD for 6 cycles cycles. This was not based on RATL because RATL was not published at that time. Versus AAVD, wherein the bleomycin was replaced by Brentuximab. And if you look at what was the primary endpoint, which was the PFS, it was met. The 3-year PFS is 76% for ABVD and 83% for AAVD, which basically translates into a 30% reduction in risk of progression and death. Now, I do have to say that AAVD is a lot easier for me to give because I don't have to worry about interim PET. As long as there is no progression, you can keep going, and the PFS is as equivalent to someone getting BACOP. On the other hand, it's important to be mindful of toxicity. It's not an easy regimen to give. So with toxicity, pulmonary toxicity is definitely less as compared to ABVD. However, peripheral neuropathy is more. So a lot of times by cycle 4, 5, and 6, I'm really going down on the doses of not only Brentuximab, but also Vinblastine. So remember, there is less pulmonary toxicity, more neuropathy, and it is mandated that you give growth factor support to these patients every 15 days when they get their chemo rounds. So moving forward, elderly Hodgkin lymphoma patients. Remember, there are 2 spikes. You get it either in the population of 20 to 40 or over 65. So my group that was headed by Ajay Major actually looked at the National Cancer Database analysis, and we found that patients who are older than 65, they actually did not have an 80% cure rate, but only had a 60% cure rate. Primarily because they have comorbid conditions which do not allow us to give ABVD or AAVD. The one take-home point, remember, for people who are 65, please do not give bleomycin. They do have a higher risk of getting bleomycin toxicity. On the other hand, what to do for these patients is something that we are still exploring. And these are the 3 clinical trials. These were all single agent. Single agent Brentuximab was used in elderly patients. CR rate was great, 73%, but the PFS was only 10 months, which means after 10 months, patients relapsed, and then you have to put them on one therapy after the other. Jonathan Friedberg tested Brentuximab plus dacarbazine. The CR rate was good, and the PFS was 17 months. On the other hand, Bendamastine and Brentuximab is a combination that is very good, but it actually causes toxicity in older adults. So you may want to dose reduce, but typically I tend not to use it. I have seen people respond better with Brentuximab-based therapy, but I do have to say this clinical trial that was published eventually in the JCO by Andy Evans actually had a very interesting way of treating elderly patients. So what they did was they gave 2 cycles of Brentuximab, let the tumor calm down and reduce slowly, and then added AVD for 6 cycles, and then capped it off with Brentuximab for 4 cycles. With that, the CR rate was a whopping 80%, and the grade 2 peripheral neuropathy was not at all bad. It was manageable. Grade 3-4 was only 4%, and the 2-year PFS was 85%. So this is something that I would have to say I do it a lot in my clinical practice, wherein I slowly, gently introduce chemotherapy. Relapse refractory Hodgkin is a big issue. And for those of us who have seen young patients come to our clinics with failure of one line of therapy after therapy, we know there is a lot more to be done in this disease. Typically, when someone comes to you, you want to assess them for transplant fitness because transplant gives them a second chance at a cure. And this is an auto transplant. But in order to take them to an auto transplant, patients have to have a PET negative remission. And on the right side, you can see that if the PET is negative, then the benefit of an auto is nearly doubled. So the big question is, how do we salvage these patients? With what? Previously, age-old, we have used DHAP, we have used ICE, we have used GVD, GDP. These are not bad regimens, but the CR rate is somewhere between 9% and 20%. However, there are 2 new regimens that really have shown a whopping CR. Number 1 is Brentuximab plus Bendamastine. 4 cycles of this regimen was given, and it showed a CR rate of 74%. There was no issue with stem cell collection because there was a concern with the Benda, and people could actually go through auto transplant without any issues. So for my patients who I initially treat with RATL and then they relapse, this is my go-to regimen in the salvage setting, which is Brentuximab plus Benda followed by an auto. Interim results of this clinical trial also looked very promising. My colleague Alex Herrera at the City of Hope presented Brentuximab plus Nivolumab. And he actually did show that 4 doses of that was able to take patients to an auto transplant with a 2-year PFS of 92%. So keep a watch on these 2 regimens. They are very soon going to make a huge coming in this field. So with respect to update number 4, take a look at the CR rates of these 2 regimens that I showed you, and now compare with the CR rates that I showed you with the salvage regimens. And clearly, although this salvage regimen previously was a CT-based CR, and this is a PET-based CR, you cannot help but wonder that Bendamastine Brentuximab is not only efficacious, but it's also less toxic. Patients don't have a lot of side effects. This was update number 5, which is the Athira trial, wherein patients who are high risk for Hodgkin relapse, remember these are patients who will continue to have a relapse. Is there anything we can do to prevent that from happening? So they really picked peculiar high-risk patients, for example, people who are refractory to frontline therapy, patients who relapse within 12 months, patients who relapse more than 12 months but with extranodal sites. These are the patients they randomized after an auto transplant, roughly around day 30 to 45, to getting Brentuximab or placebo. Brentuximab was given for a total of 16 cycles, and they saw that the median PFS nearly doubled if you got Brentuximab. But remember, this is something that I use if a patient really meets the eligibility criteria. So I wouldn't do it for someone who relapsed more than 12 months out without any extranodal sites. That would be a real, resource draining practice pattern. But on the other hand, if someone is refractory to ABVD, I take them to an auto, then I do put them on maintenance Brentuximab. PD-1 inhibitors made a big splash, and you can see with Nivolumab or Pembrolizumab, all the 2-year follow-up studies continue to hold up. So currently in the relapse refractory Hodgkin lymphoma space, you have Brentuximab that is approved after 2 lines of therapy failure. You have PD-1 inhibitors that are approved after 2 lines of therapy failure. And that brings me to the last abstract, which was presented by Dr. Kuruvilla from Canada at the recently presented ASCO 2020, wherein we have these 2 agents that are approved in the relapse refractory setting. Which one is really better? So they actually took patients who relapsed after an auto, who relapsed, who were ineligible for an auto. Previous Brentuximab was allowed, but previous Pembrolizumab was not allowed. And you can see that the median lines of therapy was similar. Overall response rate was higher in Pembrolizumab. CR rate was equivalent, but the grade 3-5 adverse events were less in Pembrolizumab. And based on that, the PFS was also much more significantly improved in patients who got Pembro. The median PFS was 13 months versus 8 months in Brentuximab. So I anticipate that moving forward, if my patients are naive to Brentuximab and have failed, and now they went through an auto and they failed, and if I have a choice between putting them on a PD-1 inhibitor or Brentuximab, then I will choose a PD-1 inhibitor for the PFS benefit. Similarly, if patients are older, they cannot get to an auto transplant, and if I have to choose between the 2, this trial basically makes me change my practice in clinic and move over to Pembro or Nivo. So these are the conclusions of my talk. I think huge advances are coming at this point in time. Stay tuned. It's extremely important to recognize that precision medicine is going to take norm and it is going to move forward. We have to be very agile in making sure that MRD analysis, gene sequencing, immunotherapy, that's really where the world is heading. Chemotherapy hopefully will remain redundant in a decade. Hopefully I'm not talking about R-CHOP, I'm talking about something else. But at the same time, it's very important that this care be delivered all over the world to resource good as well as resource not so good institutions. As a result of which we need to also devise less expensive treatments. I recognize that is something that the US continues to do because expensive treatments get approved because insurance pays for it, but at some point the system will collapse, and therefore it's very important that we design not only more efficacious but less toxic and cheap therapies. So with that, I'm hoping that this was helpful, and I will move the screen back over to the presenters.
Thank you, Manali. That was wonderful. Now we have two jobs. One, we had sent out certain emails and we have received some questions for you to answer. And we also had 12 questions in the question box over here. So first I will take up the questions which have come to us by email. They may not be related to your presentation. Is that okay for you?
Yes.
They are related to lymphoma. So we have Dr. Parthiv from Bhavnagar. He has a patient of EB virus-related lymphoproliferative disorder causing a significant lymphadenopathy and systemic symptom. He has not improved after 3 months of observation. What do you do to these patients? EB virus-related lymphoproliferative disorder, significant lymphadenopathy, systemic symptoms. They just observed him for 3 months, but he is not settling. He wants to know what to do.
So I think it all depends on patient fitness, etc. But I typically, for patients who are EBV proliferative, lymphoproliferative disorders, or people, same situation would be post-transplant lymphoproliferative disorders. Typically, I give them 4 weekly doses of rituximab and see if they respond. If that doesn't work, then in that case, I do pull in chemotherapy. But in this case, I think doing 4 weekly doses of rituximab, doing a repeat PET scan, if the PET scan shows a response, you can actually give 4 additional doses of rituximab, will, I think, be helpful for this patient.
Thank you, Manali. So, Dr. Parthiv, you got your answer. Dr. Kajal from Ahmedabad. In a person who has developed grade 3 peripheral neuropathy after 3 cycles of R-CHOP or DLBCL, can I drop vincristine and replace it with vinblastine?
So I think at this point in time, I have some data that is coming out of my center. We looked at patients who were given R-CHOP or R-EPOC. Frequently, by the end of 4th cycle, people will develop peripheral neuropathy. It is important that we don't make them disabled from peripheral neuropathy. So our data was really looking at what if we drop the vinca completely? Does it compromise outcomes? And the answer is that it does not impact outcomes. So a lot of times after the 4th cycle, such as in her case, I would completely drop vincristine. Doing vinblastine instead of vincristine is not reasonable because it belongs to the same family of agents, which is vinca alkaloids, as a result of which if you're trying to limit the neuropathy, that will not happen. So my recommendation would be to drop the vinca completely.
Thank you. So Dr. Kajal, that was the answer for you. Dr. Priyanka from Karamsad, Surat. She has a 58-year-old man with primary CNS lymphoma. HIV status is negative. After 1 cycle of matrix therapy, there was a life-threatening aspergillus infection. What should be her next protocol?
This is very tough. We all have gone through something very similar. I would have to say that, of course, recovery from this infection is vital to be moving forward. But at the same time, if something like matrix doesn't do its job, then just doing our high-dose methotrexate once the infection is completely resolved would not be unreasonable. And if the patient does really well, then in that case, to bring in either some cytarabine might be helpful versus you keep going with our high-dose methotrexate. But our goal is typically to get them to an auto-transplant. And the conditioning regimen that we use is thiotepa. On the other hand, if the patient is not auto-transplant eligible, then in that case, your guess is as good as mine, in which case we may take a whole brain radiotherapy, but it causes a lot of cognitive damage. So therefore, I would say once the patient gets better, I don't think you can give him matrix again, but maybe challenge him with high-dose methotrexate with the methotrexate dose of at least 3.5 grams per meter square.
Thank you, Manali. Dr. Amit from Rajkot has asked, he has a 32-year-old man who has developed post-renal transplant Hodgkin lymphoma in para-aortic lymph node. Patient was on steroids, MMF, and cyclosporine for 2 years after transplant. What will be the best management of this patient?
So with post-transplant lymphoproliferative disorder, we need to know if it is early proliferative or not. This seems like a proper clonal Hodgkin disease. So the first thing I would do is talk to the transplanters and go down on immunosuppression. Number 2, treat him like Hodgkin disease, which would mean stage him and then treat him with the available standard of care.
Thank you. Dr. Tanvir from Surat. How do you treat DLBCL in cardiac compromised individual?
So for DLBCL, every institution has a very different way of approaching. For people who are cardiac compromised, I typically do not use anthracycline, and instead of the anthracycline, I replace it with etoposide. So I typically give RCEOP. That's my go-to regimen. I use a lot of EPOC in my clinical practice because I feel like the infusional is a lot better to handle. So if I was to choose something similar for a cardiac compromised individual, then I'll drop the H of EPOC and still give the remaining in an infusional fashion. It's a lot easier to tolerate, but RCEOP is absolutely fine.
Thanks. Dr. Madhuchanda from Kolkata. Is fertility preservation an issue in an adolescent girl undergoing ABVD treatment for Hodgkin? And if yes, what steps do you take?
So that's an excellent question. I am very, very heavily invested in making sure that the fertility of my patients is not compromised. So typically what I do for my patients who walk into my clinic with a new diagnosis of lymphoma, and if they are going to get chemo, and if they are under 45 years of age, I typically have them see a fertility expert. But there are times, such as in this doctor's patient, wherein you can't wait, in which case I would have to say, finish your ABVD, hopefully she'll get to a cure. About 1 year after completion of ABVD, send her for fertility check. Make sure FSH, LH, AMH all gets checked. And if those numbers look poor, because typically by 1 year, those numbers should start looking good again, you have to it'll be helpful to send the patient over to a fertility expert.
Thanks. Dr. Girish from Hubli. Is R-EPOC, without making any dose adjustment, superior to R-CHOP?
So this is a lot of extrapolation. There are no clinical trials that suggest that. The beauty of R-EPOC is really the dose adjustment, because it's the area under the curve that you're really trying to target. And the area under the curve is very different for different patients. Therefore, I think infusional doses are important, and therefore it's important to go up or go down based on the nadir labs. But if you ask me if R-CHOP is equivalent or superior to non-dose adjusted EPOC, I would have to say I would then consider R-CHOP because it's a lot higher dose of cyclophosphamide. You're looking at a curative malignancy, therefore I believe you have your first shot is your best shot.
Thanks. Dr. Boben from Kerala. How do you treat gray zone lymphoma?
So gray zone, I do have interest in gray zone. We actually published our work with nivolumab in the New England Journal of Medicine. Gray is so gray that no one even knows how to spell it, whether it's GREA or GRAE. But gray zone lymphoma is really in between non-Hodgkin and primary mediastinal B-cell lymphoma and Hodgkin. So typically I treat them with dose-adjusted EPOC-R. These are patients who typically present with mediastinal masses. And in patients who are primary mediastinal B-cell lymphoma, we now know that dose-adjusted EPOC without radiation treatment gives them a PFS of over 95%. That is not the same with gray zone. So with gray zone, the PFS goes down to 75%. So typically I start with dose-adjusted EPOC-R, and if they have a bulky mediastinal mass, irrespective of whether it's a male or a female, I try to consolidate it with data.
Thank you. Dr. Sarita from Delhi. After R-CHOP, should radiotherapy be given to all extranodal DLBCL?
So, there are two trials. One is the Recover 60, the second is the Optimal trial. One was in older patients, one was in younger patients. And the gist really is that if you have a non-bulky site that has completely gone into a remission, PET of Deauville of 1 to 3, then you can actually escape radiotherapy. So typically, I do not consolidate with radiation treatment. However, if there was bulky disease to begin with, then I consider radiotherapy.
Thank you. Dr. Shada Shivadu from Hyderabad. How do you manage curable aggressive lymphoma first diagnosed in 5th month of pregnancy?
So it depends on what type of lymphoma you're really looking at. There is the first trimester, there is the mid trimester, and there is the late trimester. Typically, first trimester option. So for Hodgkin, it's a lot easier because for Hodgkin, there is data to suggest that beyond the first trimester, you can actually go forward with standard ABVD. I don't do ABVD, I do AVD. Joe Connors from BCCA actually published that you can just do some Vinblastine to get the patient delivered and then give them full doses of chemo. If someone has diffuse large cell lymphoma, then it's a bigger conversation to have. I would say the last trimester, just keep it going with some steroids till the baby delivers. The mid trimester becomes a little bit of a question mark, in which case we have to have the conversation. And because it's something that is curable but potentially life-threatening, we do recommend chemo. The first trimester is when you do have to talk about, unfortunately, you have to talk about the possibility of losing the baby. Now, in indolent lymphomas, on the other hand, you can safely observe. Don't even worry about it. If push comes to shove, then you may want to give some rituximab after the second trimester.
Thank you. Dr. Mitesh from Surat. Is R-mini-CHOP a curative regimen for elderly DLBCL?
Yes, R-mini-CHOP is a curative regimen for elderly DLBCL, but the cure rate is not 60%. The cure rate drops by about 20%. This typically is offered to people who are older than 80 years of age, and a lot of clinical trials are being devised. For example, R-mini-CHOP plus LEN was compared to R-mini-CHOP at ASH 2019, and it was a negative trial. Similarly, R-mini-CHOP plus azacitidine is currently being compared, so we only know. But until then, yes, there is a curative option, but the cure rate is not even closer to R-CHOP. It's probably 20% lower than R-CHOP.
Thank you. Dr. Vibha from Vadodara. Do you ever do splenectomy as a treatment for lymphoma?
So I typically consider a splenectomy for patients who have a splenic marginal zone lymphoma with not a lot of bone marrow involvement. There is some data to suggest that if you take the spleen out, then the reversal of bone marrow changes will also happen. But a lot of times when I have done that in patients with thriving bone marrows, then the reversal doesn't happen, and eventually patients have to get on some sort of immunotherapy like rituximab. At the same time, I don't really recall the last time I have removed a spleen for someone with lymphoma. On the other hand, just remember that before removing the spleen, please vaccinate them for perisplenectomy vaccinations like H flu and pneumococcus and meningitis. Wherein the PET scan had an SUV of 20, I wanted to be sure that the patient truly had transformed. There was no other site to biopsy, so that's when I took out the spleen, and the spleen was riddled with diffuse large cell lymphoma. So these are the two conditions I would say I do it, but I have started doing that a lot less because I see that in splenic marginal zone lymphoma, just doing single agent rituximab does its job for at least 5 years.
Thank you. Dr. Avinash wants to know a similar question. Do you do splenic biopsies?
So it all depends on how brave your interventional radiologists are. And if you have a good collaboration with them, I have been able to convince a few to do splenic biopsies because I do believe that sometimes it is extremely helpful without the patient having to lose the spleen.
He has one more question. Outside CLL, where do you use obinutuzumab as a preferred monoclonal versus rituximab?
So I typically use it because it is available in frontline follicular lymphoma management for high tumor burden. And that is based on the Gallium study, which compared chemo rituximab to chemo obinutuzumab, and there was a PFS benefit. But the most important thing was there was MRD benefit with obinutuzumab. And at ASCO of 2020, they also showed that people who got obin as frontline, they actually had a lower chance of having POD24. So for these reasons, I try to get them on obin plus chemotherapy.
Dr. Sailesh from Ahmedabad, what is your schedule for preventing infections in lymphomas? And then, so your schedule for preventing infections during treatment of lymphoma with respect to antimicrobials, antifungals, vaccination, and intravenous gamma therapy.
So with respect to antimicrobials, I typically put all my patients who get on any sort of chemotherapy on an antiviral like acyclovir. I put them through the treatment course. Typically, I give them antibiotics such as levofloxacin or cefpodoxim for 7 days after each chemo round, especially if they are older patients. Fungal prophylaxis I typically do only for patients who get dose-adjusted EPOCH-R, for double hits, aggressive B-cell lymphomas, or for people who are getting R-CHOP and they are older than 60. That's when I do fungal prophylaxis. With respect to your question about IVIG and vaccination, IVIG I typically give for my CLL patients if they have recurrent infections. And for me to pull an IVIG, I would definitely have to see an IgG number less than 400. But just treating a number is not what I do. It has to accompany infections. And I would say about 2 to 3 infections per year that needs the hospitalization or antibiotics is what triggers me to do IVIG. I also do a lot IVIG for people after CAR T therapy because they are B-cell aplastic. So for those patients, just the number is enough. So if they go under 400, I give them IVIG. With respect to vaccination, I think all patients who are older than 60 should be vaccinated. Pneumococcal vaccination, annual flu vaccine, the newer shingles vaccine is important, especially for CLL patients. Now, of course, for indolent lymphoma patients, we don't do live virus vaccines. We can only give them dead virus vaccines.
Thank you. Dr. Suti from Kathmandu, can angioimmunoblastic lymphoma be treated by immunomodulation and avoid chemotherapy?
So there was a lot of hope that angioimmunoblastic AITLs could be treated with cyclosporin, with lenalidomide, with just rituximab. And all of those studies showed that the responses were there. However, the PFS wasn't maintained. So we typically bucket them together. However, it's important to know, like he said, that for AITLs, people also have a lot of autoimmune issues. So people can have rashes and people can have a Coombs positive, people can have an IgM clonal that pops up. So beware of that.
Thank you. Dr. Abdul Shahid from Port Blair, in CD30 positive peripheral T-cell lymphoma, should Brentuximab based protocol be the first line of therapy, and should all the patients be followed by upfront transplant?
So, great question. This is basically based on the clinical trial Echelon 2, which compared CHOP, which is CHOP, to CHP plus Brentuximab. And in this clinical trial, patients needed to have a CD30 expression of at least 5%. And then later on, they went and saw as long as they have 1% expression, they would be fine. And this clinical trial actually was a very well conducted trial, which led to CHP Brentuximab being the now approved standard. However, a lot of us do EPOCH-R in our practices, so we're not sure how that relates to it. But especially for ALK lymphomas, which are heavily CD30 positive, we absolutely give them CHP plus Brentuximab. Outside of ALK positives, all the others, we still take them to an auto transplant because that question wasn't quite answered in that clinical trial.
Thanks. Dr. Shekhar from Goa, what is your preferred protocol for first relapse of DLBCL after R-CHOP if the relapse has occurred within 1 year of first line of therapy? You have answered it, but you can just in short answer this.
So I think within 1 year of therapy, that basically means that the patient is going to have a very bad prognosis. So that's the Scholar 1 analysis that we talked about. And this is where I absolutely want my patients to go on a clinical trial. I have a trial wherein people get randomized to an auto transplant versus CAR T if they have relapsed within 12 months. However, outside of a clinical trial, I definitely still go with salvage. If the patient is transplant eligible, I prefer DHAP, RDAP. If the patient is not transplant eligible, I do Pola-BR. I'm actually developing an investigator-initiated trial in first relapse DLBCL, wherein I'm planning to give Pola-BR for even transplant eligible. So we'll see how those trial results pop up.
Thank you. Dr. Malvi from Bhopal. Do you give both intrathecal and systemic high-dose methotrexate to prevent CNS collapses?
That's a great question. I can tell you what I do in my clinical practice. So typically when we talk about prophylaxis for CNS, we look at the CNS IPI score as well as other high-risk sites. So for a CNS IPI score of more than 3, or for patients with testicular, breast, extranodal, epidural, bone marrow involvement, these are the patients that I do CNS prophylaxis. And there was actually just data published from EHA, wherein they showed that if you try to mix high-dose methotrexate in between your R-CHOPs, you may end up delaying treatment. So that's pretty much what we have also done, which means if I do R-CHOP or if I do R-EPOC, with every cycle, I give intrathecal methotrexate once. And then after completion of all 6 cycles of R-CHOP or R-EPOC, I give 2 doses of high-dose methotrexate. I would recommend that she also refer to this really amazing article in Blood by Chan Shea. He's the first author, wherein he's talking about CNS prophylaxis, and that is something that he also recommended. High-dose methotrexate, remember, going under 3 grams is not going to reach the brain. So if you're not going to do over 3 grams, please don't do high-dose methotrexate. It'll just cause toxicity.
He has one more question attached to this. Do you give rituximab with high-dose methotrexate?
I don't give rituximab with high-dose methotrexate because I believe that the 6 doses that have shown help have already been delivered with the CHOP.
Dr. Afak from Srinagar. Should we use ABVD or R-CHOP for patients of nodular lymphocytic predominant Hodgkin?
So your guess is as good as mine, but there was a single center study done by Michelle Fanali at MD Anderson who actually did show that R-CHOP was slightly superior to ABVD. So I use R-CHOP in my practice. I also use R-CHOP if I'm worried about transformation. And typically you start worrying about it when patient has abdominal lymphocyte predominant Hodgkin. So my go-to for NLHPD would be R-CHOP.
Dr. Javed from Srinagar again. How do you sequence the treatment of relapsed Hodgkin lymphoma between high-dose therapy, Brentuximab, and checkpoint inhibitors? How do you sequence them?
So typically when a patient with relapse comes over to me, I would like to know how long has the patient been in remission and if the patient is transplant eligible. I assume that the question is for transplant eligible patient, so I'll take it that way. So if a patient walks into my clinic with first relapse, I try to get them into a remission with a salvage treatment. You can do ICE, you can do DHAP. I tend to do Brentuximab plus Bendamastine. But if the insurance doesn't cover or anything like that, then I try to give ICE. Give about 2 to 3 cycles. If the PET shows a response, which is a double 3 at least, then in that case, I take them to an auto transplant. Post-auto transplant, the question is this patient high risk? And the high risk category would be the Athera eligibility criteria. And if the patient meets the high risk category, then I put them on maintenance Brentuximab for 16 cycles. If they relapse after that, meaning if they relapse after an auto transplant, then it depends whether the patient has ever seen Brentuximab or the patient has not seen Brentuximab. If the patient has not seen Brentuximab, then I tend to give them Brent first and try to get the best bang for the buck. If they relapse after Brent or they have seen Brent before, then I do PD-1 inhibition. The big question is when can you do an allo on these patients because they are typically young. And once they start relapsing on Brent, remember PD-1 inhibitor is your only chance. And that too with a CR of 20%. There are some patients with long-term remissions on PD-1 inhibition, but to be fair, I typically consider them for an allo, at least get them to a bone marrow transplant expert to have the discussion.
Thank you. Dr. Prabhu from Bhubaneswar, is upfront autologous transplant a must for a transplant-fit mantle cell lymphoma? Is it a must?
So I think this is a question that is evolving. Like I did allude to the fact that if someone is TP53 mutation positive, please do not take that patient to an auto transplant. At the same time, auto transplant has its benefit. I do believe it does. It can give you a PFS of over a decade if you look at some of the older trials. So if someone is fit, non-TP53 mutation positive, is in a remission with chemoimmunotherapy, then the benefit of an auto is an additional 5 years over chemo alone. So again, you cannot cure mantle cell. You have new drugs that you can target when mantle cell comes back. But my aim would be to take them to an auto. Now, there is a clinical trial that is being devised based on MRD. So if someone achieves an MRD negativity after upfront chemoimmunotherapy, these patients are getting randomized to getting an auto versus just maintenance rituximab. So that will help answer that question, whether everyone needs an auto.
Thank you. Dr. Singh from Patna, do you use bortezomib upfront for any lymphoma?
So I actually have not, except for maybe a CD38 positive lymphoma. I have used it in plasmablastic lymphomas with bortezomib plus EPOC. I have tried to do that, but it's a toxic regimen, and I don't remember if I have used bortezomib upfront. There is some data in older mantle cell lymphoma patients that BR-CAP is better than R-CHOP, but I rarely use that regimen. So again, I don't use bortezomib.
Dr. Gogoi from Guwahati, what is the role of ibrutinib in the treatment of DLBCL?
Ibrutinib actually is helpful in patients for palliative measures. There was the Phoenix trial that compared R-CHOP versus R-CHOP plus ibrutinib. It didn't show any benefit, unfortunately, but there was a stratified, which wasn't pre-stratified, but people ages less than 65, they actually did have a PFS benefit if you added ibrutinib. So upfront, I don't use ibrutinib at all based on that data. In the relapse refractory setting, I think ibrutinib does show responses, and I have typically used them in non-germinal center relapse refractory DLBCLs.
Thank you. Dr. Govind from Jodhpur, we use DAR EPOC for double hit lymphoma. Should we use it for double expressor? And should we do this for non-GCB DLBCL?
Excellent question. I think so. The CALGB trial compared R-CHOP to DA EPOC, and that was a negative trial. They had very few double expressor lymphoma patients. There was no benefit between GC and non-GC. But having said that, I typically do dose-adjusted EPOC-R for double expressor lymphomas. I do that, but for non-GC, I don't.
Thank you. Dr. Pankaj from Bikaner, is CAR-T the best option for DLBCL refractory to R-CHOP?
So, if you're saying refractory, that basically means the patient hasn't responded at all. So if the patient hasn't responded at all, currently there is no standard of care. And now we have been able to salvage maybe 20% with the salvage followed by an auto, but I have seen more benefit with the CAR. So unless and until this clinical trial pans out, I wouldn't be able to tell you with definitive evidence that CAR-T is better than auto.
Thank you. Dr. Sachin from Udaipur, do you do interim PET outside Hodgkin for any other lymphoma?
So again, it could be just a resource-driven place that I am in, but based on the NCCN guidelines as well, yes, I do an interim PET for diffuse large cell lymphoma. I do an interim PET for mantle cell, follicular. I do an interim PET.
Okay. Dr. Pawan from Jaipur, do you use MRD assessment as a clinical tool?
I do, because we have the availability at the university to do it. MRD basically is really a discussion point right now, primarily for CLL patients, in my opinion. Especially, I have many patients who are now finishing up their venetoclax plus obinutuzumab after 12 months of treatment, and it helps me to know whether they are MRD negative or positive. If they are MRD negative, I feel much better at stopping the combination. If they're MRD positive, nobody knows what the answer is. They can continue to relapse even if you stop. They can continue to relapse even if you take it out. So it definitely gives me a gauge on follow-up for these patients as well.
Dr. Tushar from Chandigarh, your views on combining Ibrutinib with venetoclax first-line therapy in CLL?
I think it's something that is going to become a huge discussion and probably going to become a new standard of care. So there was the Captivate study that was presented, as well as a couple of studies presented by Nitin Jain at MD Anderson, wherein he looked at Ibrutinib plus venetoclax. There is a Matt David study at the FCI, which is talking about Acala, venetoclax, and obinutuzumab, so AVO. The whole idea is give them together for 15 months and then take it away, hoping that when you do it together, the resistant clones don't develop as quickly. But to Kanti Rai's point, which is what he raised during one of the ASH sessions after John Bird presented data, was what if someone relapses after Ibrutinib and venetoclax? So you have exhausted everything then. So I think this is more of a discussion that will gain more momentum once we have more randomized data.
Thank you. He has one more question. In gastric maltoma, how do you decide between treatment of H. pylori versus chemotherapy?
So gastric maltoma, I think if you have H. pylori positive, then absolutely please treat the H. pylori first and then do an endoscopy 3 months after treatment. Do not do it sooner than 3 months. Otherwise, you'll be falsely led into believing that you haven't cured it. So if the endoscopy shows just specks of MALT lymphoma, the remaining is gone, wait for 3 more months, do an endoscopy again. You might see clearance. On the other hand, for people who do not respond to H. pylori therapy, then I would say radiation treatment is my go-to for gastric MALT lymphoma. Chemotherapy, I don't remember using over the last few years I've been in practice.
Thank you. Dr. Ekbote from Aurangabad, what are your indications for radiotherapy as upfront treatment for primary CNS lymphoma?
I am not in favor of whole brain radiotherapy as upfront treatment for primary CNS lymphoma unless and until you're really looking at multiply relapsed CNS lymphoma or CNS lymphoma in an extremely frail and old patient wherein you just want to palliate symptoms. That's the only time I do radiotherapy.
Thank you. Dr. Mukesh from Raipur, do you recommend R-square as upfront treatment for follicular lymphoma?
So the relevant study basically showed that R-square was equivalent to Bendamastine rituximab. However, it did not meet its statistical endpoint. Therefore, it is not FDA approved right now. However, there are patients who like the idea of being on a non-chemotherapy regimen. So that's when I am able to do R-square for them. On the other hand, there are people who don't like R-square because R-square is given for a much longer period of time than BR, which is only for 6 months. So I personally haven't struggled with that distinction point. So I still use a lot of BR upfront in my practice if I decide to choose to treat them for high tumor burden follicular.
Thank you. Dr. Madhukar from Varanasi, do you use lenalidomide maintenance after DLBCL in elderly people?
A great question. This was based on a clinical trial called the Remark study by Catherine Thiebelma, and she basically showed that there was a PFS benefit to doing patients lenalidomide maintenance, but there was no overall survival benefit. So I typically don't use it because there was no overall survival benefit, and I believe that for an aggressive lymphoma, you need to show a survival benefit. However, for patients who have achieved a PR after R-CHOP, they are older, they cannot get onto studies, they cannot get onto any other regimen. These are the patients absolutely I choose to treat them with maintenance lenalidomide. But because I do have the ability of clinical trials, I wait for them to relapse and then put them on an immunotherapy trial.
Thank you. Dr. Atul from Lucknow, in mediastinal large B-cell lymphoma, after DAR epoch, do you give radiotherapy to all or you are PET cycle?
So I actually do not give radiotherapy to most of my patients. Remember, after primary mediastinal B-cell lymphoma, there was excellent data presented by the NIH, which showed that if your end of treatment PET is a Doble 4, you can wait for 3 more months and do a PET. Because a lot of times these Doble 4s will become Doble 3s, which will convert them into complete responses, and you don't have to radiate. On the other hand, if it is true progression, then in that case, I would have to say, I would choose to move forward with consolidative radiotherapy because there is some data to suggest that definitive radiotherapy might put them into long-term remissions.
Thank you. There are 2 more questions left. Dr. Rohan from Belgaum. In DLBCL, do you ever give radiotherapy to bulky lymph nodes after 6 cycles of R-CHOP, even if the end of treatment PET scan is negative?
But that's the question that we discussed with the Optimal and the Recover 60 studies. I think if you talk to a radiation oncologist, they will say they will. If you talk to a medical oncologist, they will say they won't. Honestly, at this point, I do radiation treatment for previously bulky sites for my older folks, wherein I just want to consolidate them. I'm not worried about long-term issues with radiation treatment in a 70-year-old. On the other hand, if I have a 40-year-old, I will be worried about long-term side effects with radiation.
Thanks. The last question is Dr. Maniar from Mumbai. MDACC has suggested smart start for DLBCL, that is Ibrutinib, lenalidomide, rituximab before giving R-CHOP. Your comments?
So I think this is a trial that was an investigator-initiated trial by Jason Weston. And I think Smart Start with RLI was very, it made all of us very curious. That is the extent to which we can talk about that data. I think there is hope to suggest that maybe in older folks you can do something like that, get them into a remission. He actually had an anecdote wherein he said a patient of his went on RLI, got to a complete response, and then decided she didn't want chemotherapy and remains in a remission. So, these are anecdotes. These are not scientifically proven unless and until there is a randomized controlled trial or you're looking at really a palliative setting. I wouldn't do it.
Thank you. That finishes the questions we had received for you. I must say, you're a genius.
Oh, you're very
promptness with which you answer these things, and I may be double of your age, but I learned a lot. Thank you. I am amazed. In the question answer box, there are now 39 questions. There were only 11. Now there are 39. What do you want to do with them?
I'm happy to answer.
You're okay with it? Thank you so much for that. Are you able to see the questions? You want me to read it, or you can open them?
Yeah.
You can take questions which you think you have not touched upon. You need not answer all 39.
Okay. So which company does the TP53 probe? So we typically, if a community practice physician in the US does not have the ability to do gene sequencing, we send it to molecular labs such as Neogenomics. I'm pretty certain molecular labs also exist in India, although it is a little expensive, but that would be something that you would look for, especially if your FISH is negative for deletion 17p. Extrapolate data from Alliance trial to patients less than 65 and give, yeah. So most of these clinical trials, so Dr. Mittal asked this question, most of the clinical trials that I did show with Ibrutinib, they were all tested in people older than 65. And the FDA granted approval wholeheartedly by extrapolation. So basically, this is now applicable to everyone of any age with CLL. So yes, that applies to all ages. And again, underscoring that FCR is only for younger patients, non-del 17p with IGHV mutation. Ibrutinib also works in mutated IGHV. Why should we give FCR? You're absolutely right. If I ever was your patient, do not give me FCR. I will also only go for Ibrutinib. However, there are patients, to my surprise, who know data so well that I had a patient with multiple sclerosis who came to my office last year and demanded that he didn't have any high-risk features, and I do not do Ibrutinib. I gave him FCR and he's in a remission. He actually tolerated it fairly well. The trick is also about how you give FCR. Don't go more than 4 cycles. Give them lots of antimicrobials. They will need IVIG. And there is a 5% chance of getting MDS in the future.
Manali, can I ask you one thing? Is
Yeah.
it correct that 40% of patients can be cured with this FCR if they are 13q minus and they are mutated IgHV? In that case, they should get it?
So I think that's the 15-year data that is extremely compelling, that nearly 40% of patients with IgHV mutated who received FCR did not relapse. So the question is, we cannot use the word cure, but can we use the word functional cure in patients with CLL? But we can also probably make a case for Ven/Obin, wherein people get to MRD negativity, and maybe a decade from now, they have curves very similar to FCR. So it's really about what you're willing to take. But yes, this discussion has not ended, in my opinion, for younger patients with non-deletion 17p. But for unmutated, I definitely would not do any chemo anymore.
Sure.
In your practice, to whom you advise Ibrutinib and when to add Rituximab with it? I actually haven't done any Rituximab in my CLL practice. If I choose to do a CD20 antibody, I choose to do Obinutuzumab because for a higher MRD benefit. And again, with a BTK inhibitor, I have not used it. With Venetoclax, of course, I have used it.
Can I ask you one question? Have you stopped using Ibrutinib in comparison to the second generation?
I have, unless there is a difficulty getting it through insurance. I really have stopped Ibrutinib.
So there's nothing negative about Cll14.
Yeah, I think it's so much more tolerable and the efficacy is similar that I feel that's where it becomes very helpful to patients.
It's going to be available to us from next month, so this is a very relevant question for you.
Oh, fantastic. Because I'll tell you, especially in our older patients, I know of people who have literally woken up screaming in the middle of the night with muscle cramps from the Ibrutinib. And that becomes a heavy, quality of life disabling symptom. So, of course, we try to see if we can give them all the potassium, magnesium, pyridoxine replacements, but nothing really works. So, ACAL becomes a big difference. So, that's the question from Dr. Senvin. We answered that. Upfront Lenritux, I think we talked about that. Treatment of stage 4 asymptomatic marginal zone lymphoma. So asymptomatic and stage 4, I would say in a 35-year-old, assess what the tumor burden is. I typically use the Guelph criteria. So if people don't have bulky lymph nodes, they don't have cytopenias, they don't have huge splenomegaly, they don't have any B symptoms, then those are the patients you can make a very good case for observation. Versus you can also give them single-agent rituximab, weekly type 4. In the marginal zone lymphoma setting, there is some data to suggest maintenance rituximab after single-agent ritux, but these would be your 2 options to move forward.
Again, in this group, is there any place for these antibiotics, clarithromycin and all this? Does it make a difference?
So I actually only use doxycycline for orbital marginal zone lymphomas. That's the only time, and H. pylori is the only other time I have used it. But even for my orbital marginal zones, when I use doxy, I give it with radiation. So radiation is still the definitive. In the FLIER trial, 2 more cycles of rituximab was used. Yes, FLIER trial was designed way before we knew that these 2 additional cycles were of no more benefit. So that's just the design of the trial, but we do not use 2 more cycles. That's something that the Europeans did for a very long time, until I think ASH of 2018, that practice was also abandoned. What is your experience with NHLs? What is your experience with... So with high-dose methotrexate, we talked about that. With CD19-22, we are actually going to be growing our own CD19-22 at the University of Colorado, so we're very excited about this. Remember, with CD19 CAR-T clinical trial, this is for Dr. Nidhi Tiwari. For CD19 CAR-T, the basic reason for why people relapse is because there is a CD19 escape. The tumors become smarter. And they start growing and they become CD19 negative. So the idea is to implement a bicistronic CAR wherein the mechanism of resistance will go down. So not only 19, but you also try to block 22. Then so hematologist from a country offers. So if one can send apheresis cell to his country, he can produce CAR T cell and okay, sorry. Patients relapsing within, okay. So patients relapsing, this is a great question by Dr. Avinash Upadhyay. Patients relapsing within 24 months in follicular lymphoma after chemoimmunotherapy, what will be my choice? So if the patient, like he has mentioned, has transformed histology and the patient has relapsed within 24 months, then I typically give them R-CHOP, like he has suggested. I do not do R-square, and I take them to an auto transplant. Or if a clinical trial is available, then I enroll them on a clinical trial. This is also where CAR Ts are making a big splash. So stay tuned for this space. Okay. So Dr. Kannan is asking that if after CAR T patient achieves a complete response, then should we take them to an auto and CR? So typically after CAR T, we take patients to CAR T who are chemo resistant. So if after developing chemo resistance, if people have developed CRs on CAR Ts, then to take them to an auto transplant is literally just giving them more chemo. So that is something I do not do and would not recommend. However, the big question is, should we take them to an allo? Because we don't have long-term data with CAR T. And that is a question that is not answered yet. Then we have any data to recommend nivolumab post-auto for a patient who pre-auto had a PR and not a complete metabolic remission. So post-auto, I would say if you had a PR prior to an auto transplant, then you do know that the chance of a cure is not 60%, the chance of a cure is 40%. So in that case, I would say based on data, brentuximab maintenance would be my go-to. There is a clinical trial with nivolumab maintenance, but it has not panned out to be true. I would not exhaust nivolumab right now. I would probably do brentuximab based on data. About 30% of patients who achieve a CR after an auto, who go on brentuximab, have been able to maintain long-term CRs. So that's why I choose brentuximab over PD-1 inhibition. Dr. Sekar says brentuximab plus bendamastine showed 100% response rate, but excess toxicity on relapse Hodgkin lymphoma. So any study this combination in untreated. So yes, so Dr. Jonathan Friedberg actually tested this combination up front in elderly untreated Hodgkin lymphoma. He actually saw a lot of toxicity. So it is not recommended for older adults. However, as a salvage, it really is excellent. So if you can get your hands on the BV-Brent combination, people don't have to go through ICE and DHAP. But remember, with brentuximab and bendamastine, one side effect you must be aware of is a lot of infusion reactions. So make sure your nurses are very well trained to manage those. So Shilpi Saxena, Dr. Saxena says, how is MRD done in Hodgkin lymphoma and non-Hodgkin lymphoma? There are multiple ways of doing it. Typically, we do a PCR-based gene sequencing analysis. There is a company called Adaptive that actually does it. But there are multiple labs across the United States that actually have different ways of doing it. For example, Stanford's Ash Alizade's lab does it differently than the NIH. Mark Roshwesky's lab does it differently. The reason I'm also giving these names is hopefully that will help Dr. Saxena look at these papers from these labs. Dr. Mittal says, your take on DA EPOC on double expressor double hit. I think we talked about it. In early stage Hodgkin, PET-based Dovel score are for patients treated with ABVD followed by IFRT and ABVD followed by AVD. So, the one thing I do want to talk about Dovel scoring and RATL, you must have the support of a fantastic radiologist, because if you have a Dovel score of 3 or under, you can drop the bleomycin. RATL did not test radiotherapy. However, RATL also did not test that if you have a very good Dovel 4, what happens when you continue ABVD for the remaining 4 cycles and you don't drop the B. RATL did not test that. Memorial Sloan Kettering actually just had an abstract at EHA yesterday, wherein they showed that the response rates are pretty good. So there are sometimes we are in this dilemma where it's not really Deauville 3 all over, just a speck of Deauville 4. That's when you can use that data. How do you see the role of CD20 in the ERA? Okay, we talked about that. In pembrolizumab, PD-L1 expression is needed in Hodgkin or can do without. Oh, so we actually do not test IHC in Hodgkin lymphoma, because in Hodgkin lymphoma, the reason PD-1 inhibition works is because of 9p24.1 amplification. That basically causes upregulation of the locus where PD-L1 sits. Therefore, pembro or nivo works in Hodgkin lymphoma. There are other lymphomas that this PD-1 inhibition works, which carries the same chromosomal aberration, for example, testicular, CNS, extranodal NK, and Graystone lymphoma. They do carry the 9p24 aberration. How will you treat relapse advanced stage non-transplant eligible? I would say at this point, Pola-BR is approved, CAR-T is approved. If it's only for palliative setting, if it's a non-GC, you can do Ibrutinib, you can do LEN. What is the treatment of early relapse within 6 months of an auto-transplant and refractory Hodgkin? So treatment of early relapse within 6 months of an auto-transplant and refractory Hodgkin. If the patient has not seen Brent, try to use Brent. If the patient has seen Brent, try to use a PD-1 inhibitor. The minute the patient gets into a CR, and if the patient is young, get them to an allo transplant consult. R-mini-CHOP versus RCVP. My preference would be R-mini-CHOP. I think anthracyclines are important for elderly DLBCLs as well, and not all older patients have compromised cardiac function. EBV positive stage 4 DLBCL, do you treat differently? No, I do not treat differently. R-CHOP would be the standard, but don't forget to check FISH. Sometimes you can have a double hit that gets harbored in there as well. Dr. Nemani says CLL with FISH deletion 17p negative post 6 cycles of BR, progressive cytopenia, spleen, bone marrow show. What? So I'm not certain in this case that Dr. Nemani is presenting at this point if the bone marrow shows persistent disease, that Ibrutinib actually has any issues with starting. Ibrutinib does not cause a lot of cytopenias. In fact, it will cause initial lymphocytosis. So again, I think this was probably in the time that we all used to do BR, but at this point we no longer do BR. Also for the reason that sometimes BR can cause prolonged hypogammaglobulinemia and infections in older patients. We talked about radiation treatment in CNS lymphoma. So I think this is what Dr. Abdul Shahid is probably suggesting. 33-year-old Hodgkin lymphoma, stage 4, extensive extranodal, multiple skeletal sites, showed excellent response to 6-ABVD, but a small uptake of SUV4 in mediastinum still remains. How to go about this? So I think at this point you can have two choices. You can either do, this is a very high risk patient, number one. I think his IPS score is over 5. So this patient can be managed one of two ways. Number one, if that's the only site, you may want to consolidate with local RT, or wait for 3 months, get another PET. The PET will also be telling, because if this disease is going to come back, it will come back within 3 months. So that will give you an idea. Sometimes these SUVs in the mediastinum actually resolve and they shrink. Also, don't forget that sometimes people, I have had strange cases where mediastinal uptake persists. So make sure you get a biopsy, because frequently people can even have granulomatous disease, especially in our country like India. Dr. Akhtar says for relapse of follicular, after two years of post-R-CHOP, he was treated with Obin-Ben, now in CR, evidence by, what should the approach be? So yes, so if you choose Benda Tuzumab for 6 cycles at relapse, then based on the Gadolin study, you can actually make a case for maintenance Tuzumab. So I actually would recommend maintenance Tuzumab, especially because the patient has achieved a CR. So that's something I would recommend. Any role of ACE or in patients at high risk for cardiotoxicity and need treatment with anthracycline. So Where I work, I actually have developed a cardio-oncology program. So for people who are at borderline risk for cardiac conditions, a cardiologist sees the patient and then optimizes their cardiac health. And as part of that, some patients get started on an ACE inhibitor based on their individual risk scoring, but that doesn't apply to anyone and everyone. Ibrutinib reduces CD20 expression. What is the clinical relevance of this knowledge when combining Ibrutinib plus anti-CD20 in the context of the trial results? I actually don't quite know too much about the fact that it reduces CD20 expression. I don't know how that would be. However, with the context of the CD20 trials, it's really about getting MRD negativity. And if MRD negativity is important to you, if a CR is important to you, then add the anti-CD20 antibody. However, Ibrutinib is typically given until progression. So you're not stopping Ibrutinib. Therefore, the context of MRD doesn't quite appeal to me for BTK inhibitors. It does for venetoclax because I'm stopping treatment. But when you're looking at multiple other combinations, I think it will gain more momentum. Timelines of MRD monitoring in CLL on Ibrutinib. I do not do MRD monitoring on Ibrutinib. Ibrutinib causes partial responses. Nearly 90% of patients will have an overall response rate, of which only 10% will have a CR rate. So for your academic curiosity, you may want to check an MRD on the ones who have achieved a CR by IWCLL criteria, but typically I wouldn't act on it. Like if someone achieves a CR, if the patient is MRD negative, I'm not stopping Ibrutinib for those patients. Therefore, that would be a huge extrapolation. But what would be the salvage treatment for progressive Burkitt lymphoma post-CODOC or IVAC? So this is probably one of the toughest scenarios we have gotten into, wherein after CODOCs or IVAC, patients progress with Burkitt. These patients historically don't do well. You can try to get them on a clinical trial. You can try to give them a salvage. If you do give them a salvage and if they get into a remission, my choice would be an auto followed by an allo, or just take them to an allo, or find them a CAR T cell study somewhere. But I do have to say that CAR Ts with Burkitt have not been that impressive. If patient of DLBCL is having leptomeningeal disease up front, how to go ahead? So if someone has leptomeningeal disease, it's only a matter of time that someone's going to have parenchymal disease. So typically, I try to give them high-dose methotrexate up front. So what I do is I do Mr. CHOP. Mr. CHOP is a regimen wherein you give R-CHOP and you give high-dose methotrexate around the day 10 mark. And you alternate it for even cycles. So you can do 1-3-5 or 2-4-6, so that's how I do it. Typically, if I find leptomeningeal disease, I typically start with triple intrathecal. I don't put an Omaya. I do the intrathecals twice a week until it clears, and then I go to once a week for 4 weeks. That's how I treat it. But high-dose methotrexate is your friend here because that is what is going to get rid of the disease. How you manage stage 3 ALCL, we talked about this. I would try to get them on Brentuximab chip. And at this point, if they are ALK positive, I can just watch them. DUSP22 and TP53 mutation is something that is beginning to evolve in ALCL. I think more on that once we have more established data. From Dr. Shah, early stage favorable risk Hodgkin, PET metabolic CR after 2 cycles. Can we avoid RT? No, you cannot. That was based on the study that I showed that for early stage, true favorable risk, if the PET is negative after 2 cycles, you have to still give them RT, otherwise you will have loss of tumor control. Is RDA-EPOCH an acceptable option in elderly Burkitt lymphoma? The answer is yes. RDA-EPOCH is an acceptable option, but I typically use it for low-risk Burkitt, people who don't have CNS disease, or people who are old elderly Burkitt. And I think the last question is 23-year-old female with massive splenomegaly, pancytopenia, B symptoms, BM not showing involvement. I would question the bone marrow here because typically when you have pancytopenia and splenomegaly, bone marrow will be involved, but I don't think it changes too much. In such a case with high suspicion of low-grade lymphoma, is the diagnostic plus therapy, so should we do a splenectomy here? So I would say try to get that patient another marrow biopsy, a good one. probably on both sides, to really look at the marrow. I don't understand the cytopenias otherwise. They should be coming from the marrow. And if you still don't have a answer, then in that case, I would say yes, splenectomy for diagnostic reasons would be fine.
Thank you, Manali. You answered 80 questions, 40 plus almost 39. And fantastic. What replies? Very convincing, very educational. 400 plus delegates have logged in by now. So that itself speaks of your popularity back home. And I have nothing more to say. I will hand over the stage to the sponsors, Intas, Mr. Manoj, for the vote of thanks. And from my side, Manali, thank you very much.
Thank you so much. Thanks a lot for the invitation. This means a lot to me.
Thank you. I think this is a homecoming for you. 422 delegates, Dr. Manali, from 5 other countries: Bangladesh, Italy, Sri Lanka, Myanmar, Nepal, and of course 400 logins from India. All the leading hematologists, medical oncologists have logged in. Really, really appreciate your time. 80 plus questions, and you answered them. What I also witnessed was a history. One genius calling another genius a genius. So it was a symphony of 2 geniuses together. I must have witnessed many, probably 100 plus CMEs of Professor Agarwal. Brilliant work every time, sir. I don't know how you pull it off. Fantastic lecture, ma'am. Thank you so very much also to Dr. M.B. Agarwal. All the delegates who have been very patient since last 2 hours, and really asking all the relevant questions. I'm sure it was value of your time. Last but not the least, I invite you for dinner in India at your own home. And ma'am, for you, I don't know, maybe a supper, maybe a brunch or something at your own home. Thank you very much.
Thank you so much. Thanks a lot, everyone. And I'm truly honored to be part of this. It's my way of giving back. Thank you very much, Dr. Agarwal especially. Thank you so much.
Thank you.
Have a good day, everyone.
Thank you, Manali. Thank you, my ideas, and many, many thanks to you. Thank you.